Now we have Dr. Suneeta, and she's one of the finest surgeons available. She is head of Shroff Charity Eye Hospital in New Delhi, and she does so many other things besides that, like quality control, etc. But we'll catch her today for telling us what are the newer medications available. Please.
Thank you, Dr. Harsh, and I would like to thank CIPLA for giving me this opportunity. I'll be talking on insights on newer drugs for medical management of glaucoma. So glaucoma is characterized by optic neuropathy and associated visual field loss, and the prevalence of glaucoma, POAG, is 3.54 between the age of 40 to 80 years, and it is increasing and is expected to affect 111 million people by 2040. So elevated IOP is a major risk factor for glaucoma, and lowering of IOP is currently the only treatment available. So although both laser and surgical therapy are available, topical therapy is generally what we consider as first line of therapy for both ocular hypertension and open angle glaucoma, and even for angle closure glaucoma after PI. So if you go through the medical management algorithm, we start our treatment with a monotherapy, which is generally the PG analog, and if the target IOP is not achieved, then we add a single agent to the monotherapy. And now we know that 70 to 80% of the patients after 2 years require more than two therapy. So we have a lot of fixed combinations which are with most of them are with timolol, and then we also have a combination of brinzolamide and brimonidine. So we can add any of these combination to the PG analog, and PG analog are also combined with the beta blockers. And once we have achieved the maximal tolerable medical therapy, and even if the target IOP is not achieved, we go in for surgery, either trabeculectomy, or now we can even perform MIGS procedures. So as we know, most of our drugs which we use in the management of open angle glaucoma are either aqueous suppressants or outflow facilitators, which are mainly improving the outflow of uveoscleral outflow. As we know, the prostaglandin analogs, they improve the uveoscleral outflow, or some may act by dual mechanisms. However, most of the commonly prescribed drugs, they do not specifically target the underlying cause of elevated IOP, that is decreased trabecular outflow pathway. So we know that there is a decreased facility of outflow of the trabecular meshwork, and none of the drops they target this pathway. And there was no new class of anti-glaucoma drug which was introduced for more than 20 years, but now we have different drugs, and the goal of development of new drug formulations or classes include their ability to improve the efficacy and duration of action of the current therapies, and with a favorable adverse event profile that minimizes the ocular and systemic toxicities. So you must be aware of the drugs which have been introduced in the last decade, and we have now Rho kinase inhibitors, ripasudil and nitarsudil, which are available in India, and we do not have the other drugs which are available in other countries, like latanoprostene, Bunod, which is the nitric oxide donating PGA, or E2 receptor agonists, and a combination of nitarsudil and latanoprost, which looks quite promising. So I am going to discuss about the Rho kinase inhibitors. So what is the role of Rho kinase over the trabecular meshwork? As we know, oxidative damage, stress associated with aging can lead to activation of ROC or Rho kinase in the trabecular meshwork cells. They are present throughout the body, and in the trabecular meshwork, they cause contraction of the trabecular meshwork and production of excess extracellular matrix, and which causes decrease in the aqueous facility, outflow facility. So the Rho kinase inhibitors relax the trabecular meshwork and reduce the extracellular matrix production and increase the trabecular outflow facility and IOP reduction. And they do it by relaxation of the trabecular meshwork. So the benefits of ROC inhibition in glaucoma is they may act in 3 different ways. One, as I already described, they improve the facility of the trabecular meshwork outflow. They also increase optic nerve blood flow, and they also thereby increase the retinal ganglion cell survival by improving the optic nerve blood flow, and thereby they have a neuroprotective role as well. Also, they decrease the fibrosis because of the fibroblasts, and when we do our glaucoma surgery, most of the trabeculectomy failure is because of the increased growth of fibroblasts. So they can be used as wound modulators post-trabeculectomy and reducing the bleb scarring. So now talking about the 2 commonly used drops which are available in India. Ripasudil, 0.4% eye drops, and it is used as twice daily dose. And as far as efficacy is concerned, it is effective. It reduces the IOP by 3.7 millimeters, and it is effective across all ranges of glaucoma, POAG, PACG, pseudoexfoliation, steroid-induced, etc. And it is additive to timolol and latanoprost. So these are the most commonly used drugs, and these are additive to both. And current research indicate that they have, as I have already talked about, that they have a role as neuroprotector, increased blood flow, anti-inflammatory, anti-scarring, and decreased macular thickness, and changes in the corneal endothelial cells. So as far as safety is concerned, we have been using these drops for the last 2 years now, and we do experience hyperemia. So these drugs have the propensity to cause hyperemia, although the hyperemia prevalence is more, 50 to 60%, but it is milder hyperemia, and it disappears after discontinuation of the drug. And it can also cause allergic conjunctivitis, blepharitis, and punctate keratitis. Another drug is nitarsudil, which has dual mechanism of action, and it is used only once a day as opposed to the ripasudil, which is twice a day. So as a dual inhibitor, it is ROCK inhibitor as well as norepinephrine transporter, and therefore it's a potent inhibitor of both ROCK isoforms, ROCK1 and ROCK2, and it's a prodrug. So it gets converted to its active metabolite, which is nitarsudil M1, which has five-fold greater inhibitory activity against both ROCK1 and ROCK2. As
Suneeta, just 1 minute.
Yeah.
So if I have to use nitarsudil or ripasudil, which one would you give me that, okay, you use this one?
So we have been using both, but what I feel personally is that the side effects are more with nitarsudil.
Okay.
In terms of it not only causes hyperemia, but side effects related to cornea. It can cause corneal edema, cornea verticillata also. Although all these side effects are reversible once you stop the drop, they reverse, but still they cause more side effects.
And
but some of the patients tolerate it pretty well.
Better.
Yeah.
Plus it is an OD dosage.
It is an OD dose, so if you give it in the night, then the hyperemia will not be observed that much.
But if there's a corneal problem, would you like me to give ripasudil first? Because sometimes they say that it...
Actually, there are paradoxical reports because it has been used in Fuchs corneal dystrophy.
Right.
And wherein they say that it is beneficial.
Yeah.
But the studies have shown that it diverts fluid from stroma to epithelium. And that is why it can cause epithelial edema. And the other thing, cornea verticillata is also common with this drop. So although the prevalence is not that much, but still some patients who have compromised cornea, I think we should use with caution.
Okay.
But I have not observed that many side effects with ripasudil.
Right.
But as you said, since it's OD dosage, so we are, the patient is more compliant if there's no hyperemia.
You take your time. There's no...
Okay. So it lowers IOP by 3 different mechanisms, as I said. So Rho kinase inhibition by relaxing trabecular meshwork, norepinephrine transport inhibition, which decreases the aqueous humor formation, and thereby by causing vasoconstriction of the ciliary body. and it activates the noradrenergic receptors which prolongs IOP reduction, and it also has vasodilator effect which decreases the episcleral venous pressure. So that way in patient with Sturge-Weber syndrome and all which have high episcleral venous pressure, because none of the drops act on episcleral venous pressure, so it has an application there also. So it has multiple mechanisms by which it acts. And as far as side effects that we were discussing, this is the efficacy, and the percent IOP lowering is, sorry, I'll take 5 minutes.
No problem. Go ahead.
So 15 to 22% if it is used in OD dosage, and 16 to 21%. So these are the two studies, Rocket 1 and Rocket 2, where the drug was compared to timolol. And once daily dosing of nitarsodil is found to be very efficacious with lower side effects as compared to twice daily dosage. So as we have already discussed the side effects that it can cause adverse side effects like cornea verticillata, and sometimes there is pain during instillation, conjunctival hemorrhage also. So we have noted in very few patients very small petechial hemorrhages, and cornea verticillata occurs in 20% of the patients in controlled clinical studies, and it was noted in one of the studies after 4 weeks of daily dosing, and but it was mild with no associated decrease in visual function. So even if there is cornea verticillata, the visual function is maintained, so patient doesn't complain that much. The patient is more bothered about hyperemia than cornea verticillata. And
so anyway, Suneeta, in these drugs we are using literally as a last resort.
yeah.
Okay, I think all of us understand that. So वो time ये होता है कि we say कि okay नहीं तो we'll do a trap, तो वो कहता है सर redness ही चलने दो. So yeah, that is what it is. It is the last drug. And do you agree that the beauty of the drug is that even when everything else is acting, and normally they say that if you add the fourth drug, its effect is going to be quite less. But this sometimes works wonders.
Yes.
Do you agree with that?
It is additive, definitely,
Yeah,
because
so
most of my patients, at least, they are very advanced glaucoma with very high
Yeah,
pressures.
all of our.
And you have to, yeah, yours also. So we have to give maximal medical therapy. And if you combine, what I do generally is I combine PG analog and timolol if the patient is systemically
Yeah.
healthy, brinzolamide, brimonidine, and then nitarsodil or ripasudil, whatever you like.
Yeah,
So
good.
most of the patients who have very advanced glaucoma, you have to combine all these.
Absolutely.
So I will not discuss.
Leave the trials and all, just
And now I think we are looking forward to this combination, nitarsodil and letanoprost fixed dose combination. Although I am expecting more side effects because both the drugs cause hyperemia. So I don't know how it's going to fare in terms of side effects, but in terms of mechanism of action, because letanoprost improves the uveoscleral outflow and this improves the trabecular outflow. So I think they will be really synergistic.
yes.
And they will have definitely a better IOP lowering. But in terms of safety, the studies have shown that the side effect wise, I think it is as good as using nitarsodil only. So
Oh. Yeah,
then,
foreign maybe. I talked to a couple of my friends.
yeah,
The Rocklatan that they started, the combination of this has
Yes.
not really picked up. So sometimes I really feel, because you ask any company, they will say, yeah, the combination of the drug is as good as giving them separately.
Yeah.
But I personally, whenever we are at the brink, I would rather give them separately so that you have a greater this.
No, but
Plus,
if
the timing
but
is
if
different.
You have to give 5-6 drops.
I
then it
know,
may be
but these
difficult
are the
to give
patients
them
who are going for surgery
Yeah.
otherwise. So they bloody will put it 10 times if you don't want to do the surgery.
So I think this is the last one. I think nitric oxide donating prostaglandin analog, that is letanoprostin bunod. So again, I think this is a very good combination and it's in pipeline, and it has dual mechanism of action. It acts strongly on both aqueous outflow in contrast to conventional PGA. So anything like, because PGAs are the main treatment which we're using, and if we have any drug which improves the trabecular meshwork outflow, then I think that is most welcome in our armamentarium. And this drug is hydrolyzed. Again, this is a pro drug, so it releases latanoprost acid and butanediol, um, uh, and which is further metabolized.
ये available है
to
कहीं?
other- It is not available in India, but it is available otherwise
Outside. Okay.
It has already been. So nitrous oxide relaxes the trabecular meshwork cells and facilitates the trabecular meshwork flow like nitarsudil, and it has been hypothesized that markers for NO are decreased in aqueous humor, and that lowers the NO level may contribute to increased IOP. So if we have nitric oxide in a drug form, then it will definitely improve the trabecular meshwork outflow and decrease the intraocular pressure. And it also regulates ocular blood flow and may promote retinal ganglion cell survival. And efficacy wise, I think it is better than PG analog, and it has high tolerability and compliance, and nitric oxide has a very short half-life, less than 3 seconds. So therefore it is highly unlikely that it will cause toxicity of retina. So I think that's a plus point here.
Okay.
And these are the other molecules which
I'll
I'm
leave
not
that.
going to-
Leave all
yeah.
those because they are not.
Okay.
What is there? We'll talk only about that. So anybody has a question for Suneeta, because she'll now run away. So don't ask me behind. I may or I may not know. Anything about ROCK inhibitors that you want to ask Suneeta, please catch her now. What is the half-life? If suppose you want to give a washout to these drugs, what is the expected this thing? Any clear idea?
I think not very clear.
Not, I
No,
think
no.
there's
No, I
actually
think we
this
never
is still in
talked
work
about
and
this
we have
at
not
that-
really
Yeah,
done too much work on it.
yeah.
So these are the basic things that we know. Thank you, Suneeta. Thank you very much. Oh yeah, good question.
Yeah, I
I
think
was
that's a
actually
very
had
good
written it and to
question,
ask that.
Because
Have you actually?
theoretically, I think it reduces scarring. So if we have
No,
to
have you
use-
have you done it and
No,
have?
I have not done it, but I think we
But
should.
we can try. No. Yeah, it is too early for us, but if she has theoretically written it, again,
Yeah.
like half the things we are doing because theoretically they say it works.
Theoretically.
Actually क्या हो रहा है किसी को नहीं पता. But ठीक है, there's no harm. No, both
Reticular
occur.
edema,
Both
that is
occur. We have seen
reticular
both.
edema because the fluid shifts from stroma to
Epithelium.
epithelium. So that is also seen. I have seen in 2-3 patients.
Yeah.
Verticillata is different.
Yeah. But the moment you stop,
Yeah.
within 2, 3,
So
4 days, they are gone. So we are fine with that. But yes, you are right. Both the things can occur actually. Microcystic and
Cornea
verticillata.
surgeons, they use it for fuchs atrophy and all.
Yeah, that is the truth.
Yes. Netarsudil.
Actually,
Not with repasudil.
repasudil is said to be
So
more
I-
protective
Yes.
to the
So
cornea.
I prefer still, if a patient can use it 2 times, then I prefer, repasudil. Because
Okay.
the side
Could
effect
be.
profile
Chalo.
is better.
हाँ.
It
It
is
is
used
used.
as 3rd or 4th only. That is,
And fifth also.
no, first is PG analog, second is either dorzolamide
Timolol.
or, timolol or brimonidine, whatever you like.
Then dorzolamide, then this thing, and if pilocarpine is available, then pilocarpine, then this.
Yes. Thank you. Thanks a lot.
Thank you very much, Suneeta. That was very nicely done.